Hey, welcome back to Not So Complicated. And today, this is the special request video because one of our viewer commented on making video on stroke, right? So let's begin. We will talk about types and then pathophysiology, signs and symptoms, diagnostics, and management. Okay, let's begin without further delay. So, what is a stroke actually? It is a sudden neurological deficit due to impaired brain blood flow, right? So it has different types like ischemic stroke and hemorrhagic stroke. The ischemic stroke can further be split into thrombotic, embolic, and lacunar. We will talk about their pathophysiology individually. And in hemorrhagic stroke, it's intracerebral and subarachnoid, right? So let's talk about ischemic stroke that is present in 80% of individuals with stroke, right? In thrombotic stroke, what actually happens is there is plaque formation, as like atherosclerotic plaque in vessels, and that will obstruct the lumen of the vessel and causing to reduce blood flow, right? And that will form an in situ clot, that is thrombus, and occlude again and leading to ischemia in the distal part of the vessel, and that will lead to infarction is final. So they are common in large vessels as in middle cerebral artery and are linked to diabetes and hypertension. Okay, the another one is embolic ischemic stroke. There's the embolus is actually a thrombus that is dislodged from the formation, like the place of formation, the site of formation, right? So embolus travels and that causes sudden occlusion. Like embolus can travel from deep vein thrombosis or abdominal embolus, right? So abdominal thrombus, that it can travel from anywhere by dislodging, so that will cause sudden occlusion causing ischemia and infarction. So embolus, example from atrial fibrillation or carotid artery, right? It can also form in patient who had just undergone the valve transplant, right? So it lodges in cerebral artery and that will cause infarction. The another one is lacunar. It actually happens in small vessel occlusion, as in it forms microatheroma that occludes the perforating arteries. Small and deep infarct are formed, and it basically affects basal ganglia, thalamus, and internal capsule. These are the regions of brain that is most commonly affected by lacunar ischemic stroke, right? So that is how we complete ischemic stroke pathophysiology, and this is hemorrhagic stroke that is often occurring in 20% of the individuals. The two types are intracerebral and subarachnoid, right? So in intracerebral, what actually happens is there is rupture of vessels and that leads to hematoma. Hematoma is a pouch of blood that is formed in the vessel because of rupture, and that causes mass effect, that is compression symptoms, right? Compression symptoms, since there is a load like a balloon filled with water, right? And that will lead to increased intracranial pressure due to mass effect, that is compression, and that leads to neuronal damage. That is what happens in intracerebral hemorrhagic stroke. The rupture of small vessels are often due to chronic hypertension or amyloid angiopathy, and they are also common in basal ganglia and thalamus, right? And in subarachnoid stroke, what actually happens is there is aneurysm rupture. That is already a pouch of blood is in your brain, and that ruptures. That is a popping sound is heard inside your brain, and if inside your brain or head, right? So if you feel like a popping sound is just heard after straining or waiting or lifting anything, and that you have to suspect that your aneurysm just ruptured. So what happens is this rupture in aneurysm will lead the blood in subarachnoid space causing vasospasm and ischemia. So the most common is ruptured aneurysm, that is circle of Willis, or arteriovenous malformations. So they are actually linked to polycystic kidney disease and also Ehlers-Danlos syndrome, right? So let's talk about signs and symptoms of these strokes. So ischemic stroke, the thrombotic ischemic stroke, it is gradual onset, as in while you are sleeping it can happen, and that will lead to focal deficits, that is a specific type of artery. If there is lesion, there is thrombus lodged in a specific artery, that will lead to the clinical symptoms that are associated with the blood supply of the same artery. For example, if the thrombus is lodged in middle cerebral artery, there can be a manifestation of contralateral hemiparesis or aphasia, right? So that is how it happens. And the other one is embolic. It is sudden because there is sudden dislodgement of thrombus and sudden traveling of that thrombus, that embolus in upper region of brain from deep vein thrombus or anywhere else, right? So that is sudden and maximal at onset, may have a cardiac signs as an atrial fibrillation murmur. It can happen. And the other one is lacunar. There is pure motor or sensory deficits. There are no cortical signs in this case. Example, hemiparesis without aphasia, right? So in hemorrhagic stroke, there are two types again, intracerebral and subarachnoid. The intracerebral hemorrhagic stroke often presents with headache, nausea, vomiting, seizures, and coma due to mass effect. The coma is a late feature and focal deficits based on location. If it is the putamen that is affected in intracerebral hemorrhage, that leads to hemiparesis. And in subarachnoid hemorrhage, what actually happens is there is thunderclap headache. You have to remember this. This is very high yield. Thunderclap headache, neck stiffness, photophobia, and positive Kernick's or Brzezinski's sign. You might get confused with meningitis actually. There is neck stiffness and positive Kernick and Brzezinski sign. They are the classic features of meningitis also. So the diagnosis can be dampened. There will be a lot of possible differential diagnosis. Then you have to remember this thunderclap headache and photophobia. These are differentials, like these are the symptoms that help you differentiate from different differentials actually. So let's talk about diagnostics. What actually happens is we do not non-contrast CT, that is computed tomography, and if there are hypodense areas found in non-contrast CT after 24 hours, that is infarct, like as you see in ischemic stroke. So if you find out hypodense regions, as in MRI I have attached in here, sorry, not MRI, non-contrast CT I have attached in here, so that leads to the diagnosis of ischemic stroke. It doesn't happen early because it is normal, because there is no infarct formation yet, and it happens in after 24 hours, the hyperdense region, right? So if there is hyperdense region in non-contrast CT, you have to suspect of hemorrhagic stroke, either intracerebral or subarachnoid space, right? So you can see in the non-contrast CT I have attached in here, there is hyperdense whitish area in this photo, right? The red arrows photo. There are a lot of hyperdense whitish areas. These are hematoma or anything that is causing hyperdensity. So that is how you diagnose it. There are diagnose, and there are additional methods to diagnose. You can do MRI, that is also diffusion weighted imaging, that detects ischemic if infarct within minutes, right? So you can do CT angiography or MR angiography, that is magnetic resonance angiography. It identifies vessel occlusion as an ischemic or aneurysm as in subarachnoid hemorrhage, right? So you can also check the labs like glucose, lipids, coagulation panel, cardiac enzymes for embolic sources. And the other ways are ECG as in AFib, echocardiogram as in cardioembolic, lumbar puncture as in subarachnoid hemorrhage if CT is negative. And the management of the case is done differently, right? So it is time sensitive. In ischemic stroke, if it is less than 4.5 hours of symptom onset, you have to give thromboplastin antecedent, TPA, to resolve the clot or like that, right? So if it is not less than 4.5 hours and it has been more, then you have to give aspirin. And also, is the large vessel that is involved in the case? So if it is large vessel, then you have to do the thrombectomy. The prevention for recurrent stroke are done by antiplatelets that we give, like clopidogrel, and then anticoagulation, AFib, and also statins, right? So statins are to reduce the lipid profile of the body. So that will lead to decrease in atherosclerotic plaque formation. So in hemorrhagic stroke, there are intracerebral and subarachnoid. The management is different. In intracerebral, you have to control the BP, blood pressure, by antihypertensive drugs like amlodipine, nifedipine, or lisinopril, captopril, enalapril. There are a lot. And then you have to reverse anticoagulation and do the surgery if the lesion is large. And in subarachnoid stages, subarachnoid stroke, what you do is you use nimodipine as an aneurysm repair and also monitor complications, right? So that is all about stroke. So thank you for staying with me, and subscribe for more clinical polls. And if this video helped you out, please like and comment. And if you have any special request, you can comment down and I will make a video in it. Thank you.